2 to 4. Oh my God, that's a long time. Sheesh. Sheesh. So while we're waiting for other people to join, I will give a brief update on West Virginia, who just voted in the Senate, on the Senate side, to, in effect, not eliminate, but strictly reduce harm reduction services in the state of West Virginia. So it'll be interesting to see what happens to in the House. And I think that the last minute add-on of a piece of legislation from Senator Tarr, who's the sponsor of this bill, is really to, hello Cordelia, is to add a provision back into the bill, which will require a letter of support for every SSP in the state. If they want to open up they have to have a letter of support from the Sheriff's Department, and the Sheriff's Department has the right to then revoke their license down the road if there's a violation. And it was literally, he did it on the floor, I think, which was the craziest thing I'd ever seen in my life. But it's bad, but we'll be putting out an update on it. I think we are at 2:02. I'm going to get started at 2:05. And I am going to see Antoinette Matlock. You know, my real name, and I won't tell many people this, and I don't know why I'm about to do it on this call, but my full given name is actually Antoinette. That is what the A is in A, Toni Young. Stop nodding your head, Lindsay.
And my nickname is Toni.
Right. So if anybody off of this call repeats the fact that my full name, or decides that what they want to do is refer to me as Antoinette, and I think that we will, maybe have some challenges. But so here's the funny thing, is that my mother misspelled my name. So my name is actually spelled Antionette rather than the correct way, but I'm gonna leave that alone. And so I went through my life with people calling me things like Antionette. I'm like, no, it's just a typo. Let's not go that far with it.
So even with this spelling, I have had trouble all my life, and still to this day, I'm 41. So when I pronounce my name, I automatically spell it. But I go by Toni. I just, business-wise, I put Antoinette, but I go by Toni.
Oh,
so I understand.
So you understand my plight, but thank you for joining us today. I really do appreciate it. So let's see, where are we? 2:04. We got one more minute, and then I'm going to get started. I'm going to get started with some of the most phenomenal people, and we're going to be talking about something that, I really think that this is what I like to call this topic is a predictor topic. And I think that when we try to talk to people around the country, and particularly at HRSA, at CDC, and at HHS, they're like, this isn't a problem. And I'm like, I think this is kind of like when right before Katrina, they said, the storm wasn't really a problem. And now, we know the end result. So it is now about 2:04. No, I just hit 2:05. I am really good at trying to get us in and out as quickly as humanly possible. I want to do some brief introductions. And for those of you who've never been on these calls before, you need to, I think Lee's been on maybe before, and a couple of other people have been on before. So this doesn't work like your typical webinar, right? I don't want slides. If you got them, keep them in your pocket and use them for another day. This isn't like we're going to do some didactic stuff. We're not. We're going to talk about this topic, and I'm going to introduce it in a minute. But most people who got the flyer know what we're going to talk about, and then I'm going to show you how we're going to talk about it. So the first person I'm going to have do Lee. The key word here is, the key phrase here is 2-minute or less introduction. Don't have to tell them everything that you ever done in your life. But first person to introduce themselves, Lee, tell us where you're from, what you do. Uh-oh, everybody on mute. I think Benjamin, that's you. I hate to call you up. Hey, Marcus, thank you, Marcus. You're so good to me. So first person, Lee, where are you from? What do you do there? And why do you love me so much?
Well, hi, everybody. I'm Lee Storrow, Executive Director of North Carolina AIDS Action Network, based in Raleigh, North Carolina. I use he, him, his pronouns, and we're the statewide organization doing HIV and hepatitis policy work. I've loved Toni for several years because I feel like Toni always keeps it real with me. Toni always makes me laugh. Toni's also willing to sometimes say the things that people are saying behind the scenes, but really bring it out and say it in the public. So have enjoyed being a co-conspirator with Toni for a number of years.
Thanks, Lee. It's been good riding, as the song says, riding dirty with you. So the next person is my really old friend, Joey Wynn. And Marcus just told me I have to close my curtain.
I was thinking that, but I wasn't going to say it. Yes, I'm Joey Wynn. I am the co-chair for the statewide HIV/AIDS advocacy network here in Florida. I'm in Wilton Manors, Fort Lauderdale area. I'm also the chair of the local consortium, the South Florida AIDS Network, SFAN. And we deal, even though we're a big city, at the statewide level, we have lots of rural areas in Florida. And so this was a very passionate topic for me. So thank you for the invite. I appreciate it. And why I love Toni. Keeping it real, just real, no pretension, no facades, just a reality and a reality check. And I know Toni way back when in the 90s. So yeah, we go way back.
Hang on. This is a mixed crowd. Move on.
Oh, okay. We were 4.
All right. Thanks. And the next one is the lovely Dena Gray Hughes.
Hello. Hi, everyone. My name is Dena Hughes. I am the CEO for TAN Healthcare. It's Triangle Area Network, and we are in Beaumont, Texas, Southeast Texas, right near the border of Louisiana. And we are a federally qualified health center, have a 30-year history in the community, starting out with working with HIV and Hep C, and transitioned to FQHC about 5-6 years ago. Our area is, I'm from Houston. I live in Beaumont, so urban is kind of relative, but Beaumont is one of the bigger towns in this area, but we are definitely incorporating suburban and rural communities as well.
Why do you love me?
Right. See, so this is where the term glutton for punishment, I think, is extremely, very, very appropriate. But Joey, I'm like you. I had the absolute pleasure of meeting Toni when I first started out in the HIV advocacy community. And you see the rebel, follow the rebel. There you go.
Thank you very much. Now, Jen, I don't think we've ever actually met. So you can really kind of say, you want to love me someday. It's okay. But, however you want to frame it.
Well, so we could have met at a AAA Plus conference, but you had a last minute cancel. And I got to say, I'm going to start off with why I love you. You were on a panel for AIDS United or AIDS Watch last year about serving the needs of Black women, and specifically, and you made sure to include in that umbrella Black trans men. And it was an amazing panel conversation. Like Joey said, keeping it real, from talking church to going to the beach and going to the bathhouse and meeting people where they're at. And that
whoa, did I go to the bathhouse? I didn't put that out in the street, did I?
No, I
Okay.
mean, I don't know what
I
you
just
do
wanna
on your
make sure we
personal,
keep it- Okay, I didn't know how real I got. Okay.
but that's core and central to how I view effective advocacy and effective outreach in combating the HIV epidemic is meeting people where they're at. And I think we do a really poor job of that, especially in rural areas. So who I am is a really interesting guy. And all of you can blame Joey for this because he's the one who got me into it almost a decade ago now. I'm a trans guy and a stepdad, and I live in Slidell, Louisiana, working for Community Access National Network as their policy consultant, board member for ADAP Advocacy Association. So
Woo woo, what's up, neighbor?
that's it.
Pleasure to meet you. And I want to now introduce the person who really kind of started this whole conversation in my head and for many of us, Lindsay. And I want to really just thank Lindsay for your advocacy and for letting somebody like me come go, hey, why is that happening? And now I want to know more. And now I want to go bug other people about this. And I'm really hoping that you'll lead a lot of this conversation about why this is important and how this is important. So Lindsay, I just want to also thank you for your leadership.
No, thank you. I think this is such an important topic. I think we're going to see this domino effect across the states. And so I'm more than happy to help kind of tell you what we've learned here in Texas. I'm Lindsay Lanagan, pronouns she, her, hers. I'll start with why I love Toni, because I find Toni so charming. I don't know what, like every single time I get on a meeting, I'm like, I'm so happy because Toni's on the meeting because it's always fun. It's not your typical Zoom, just like she said, this is not your typical webinar. So I have to say, I just find you so charming and I love it. And I agree with what everybody else said about being real. But I work for Legacy Community Health. We are the largest FQHC in the state of Texas, but I want to say we are one of the largest, if not the largest, Ryan White clinic in the state as well. And so we do a ton on prevention, and then we treat about 5,000 HIV positive individuals. And so happy to go over what we've been working on here in the state, and hopefully it will serve as a roadmap because we have had some success at this point. And we've worked closely with Dena and PWN. I mean, it's been a huge coalition effort. PRISM, I cannot take credit for this because we've created a massive coalition. And James Lee is on this call as well, who works with me at Legacy and is amazing. So shout out to him.
So thanks, Lindsay. And so to kind of kick us off, I'm going to do two things. One, I want to introduce David Evans. And David Evans has just joined CEG / the Rural Health Service Provider Network as our new managing director for the RHSPN. So pray for him, welcome him, and all of those things. So David, we'll let you jump in a bit, but I want to go ahead and kind of get this party started on ADAP. Right. So everybody, I think, if not everyone, mostly everyone on this call knows that ADAP is the AIDS Drug Assistance Program. And I think it would suffice to say that it is basically foundational to people living with HIV across the United States of America. And what we have seen in recent weeks, months, is many states, particularly states that did not expand Medicaid, running a deficit. And I think that my core belief is that we are going to see this in many more states that did not expand Medicaid. In particular, what we're seeing is a direct response to COVID and ADAP. That I try to be as transparent as I can about where I am and why I believe what I believe. And so, we're going to talk about state-specific stuff in Texas and Florida, in North Carolina, and across the United States. But I really believe that we were in the middle of a global pandemic. Many county and state workers were pulled off to work on COVID. And I don't know if it was Tom, Dick, or Harry, but they were, off working on COVID and said, we don't care, just make sure people keep getting their medication. And then it came time for the annual reports to be done, and it became time for reapplications to be done. And Tom, Dick, and Harry came back over to their desk in the HIV office and looked down and said, "Hey, did you realize that you are $52 million over budget?" And whoever was going yes to all of those applications for all of those people who had lost their jobs during COVID and needed emergency assistance programs said, "Yes, but you told me to keep paying for people to ensure that they got their medication in the middle of a pandemic." And that's an oversimplification of it, but I think that that's a big chunk of what happened. And now we're here. Lindsay, go.
Well, I just wanted to add a little bit of context to that. Not only was it, so what Texas did was they made the application process electronic. So it made it easier for people to sign up for the age drug assistance program, which is what you want, right? we want that to be permanent. But they also moved from 30-day refills to 60-day refills, which was a more costly, it's more costly medication for basically they absorb that cost. So not only was it an increase in the program, but it was also the difference in the days of the refill. So I don't know if everybody else's states did that, but that's Toni explains it exactly right. We kind of looked out at the end of the year and they were in a $52 million budget hole. So is it helpful, Toni, if I go over kind of what Texas did and saw? But I just wanted to add in that the longer refill days were also what contributed to the cost.
Right. Before you do that, I want to ask Joey. Joey, are you seeing something similar in Florida? I know that you're doing some work around COVID now also, but I know that your work with HIV always kind of intersects with whatever you're doing. So.
Yes, and very similar to Texas, we also started the electronic application process and moved many things that we've been advocating for many years online. So clients didn't have to physically go to a brick and mortar to be able to get their meds and get their documentation for ADAP. So that was a great thing that happened. Fortunately, we had some money that we were able to move around to supplement, but we're now looking at projections for the next fiscal cycle. Something's got to give because we've had increased people. There's no new Medicaid for them to go into. So they're falling into that traditional ADAP program. So we're scrambling to try and figure out, can we get more people in this expanded access for Affordable Care Act plans? But we're not in the situation with Texas, but we're not far off. And the state has guaranteed us that for this fiscal year, which ends in June, we're solvent. So we don't have a problem yet. But we see what's going on with Texas, and we're watching carefully what's happening with them. And we're looking at where is their money to move and reprioritize with the overall Ryan White Part B program for the state. But we're very nervous and we're watching very carefully what's going on because we're in a similar environment to Texas.
Right. So Jen, you seem to work across, all jurisdictions. Are you seeing this in other jurisdictions? Because we've heard about Tennessee, we've heard about Texas, we heard that Georgia leaped over the problem, and and maybe I'm just a natural born pessimist who's been in HIV way too long, but I just think that there's no way that the other, non-Medicaid expansion states don't get hit in the head the same way.
Well, we're seeing the issue. You mentioned Georgia. Georgia got a stopgap to fill in there. It was a 1-year funding piece. And I believe the situation with Texas also has a temporary stopgap, or they've at least pushed the precipice of some of the biggest issues off until May 30th. And that's iffy. That's iffy because these are not issues that just popped up because of COVID. They came banging down the door like the Kool-Aid man because of COVID. But this is 10 years in Georgia, they haven't increased the ADAP budget. And in that time, enrollments increased 130%. Florida was saved some of the biggest and hardest hit issues because of other spending mechanisms that Joey had mentioned. They've really maximized their rebate program. So those dollars were there to be spent down. But that even presents an issue because if you don't, Florida was looking at a risk of a reduced federal award, which means your rebate award is reduced as well, and it's a downward spiral. In Arizona, it's a Medicaid expansion state, but Medicaid doesn't cover most of the new drugs. So those folks are pushing on ADAP, and while there's not a funding issue there, when we talk about Medicaid expanded states, there are still issues in terms of policy and application that need to be addressed. Medicaid expansion doesn't address everything. When we look at the intersection of HIV and hepatitis, nearly none of the direct acting agents are covered under Medicaid in Arizona. So there's lots of little things, and they're nipping at us, and it's death by 1,000 paper cuts and being negligent. The hope on the federal level is that with this COVID relief bill that is yet to be signed and passed in the House, but fingers crossed by Thursday night we'll be done with that, that the increased subsidies will reduce some of the pressure on ADAPs. But the issue there is that clients may likely need to re-enroll under the special enrollment period because that piece for states that don't push or entities and clients that don't push for that re-enrollment piece, they'll get that back in other funding when everything's leveled out at the end of the year. But to see that immediate need met, you're going to have a massive push to have clients re-enroll, and that's a problem not just for ADAPs but for healthcare all over the place. So the pressure is there, and at the end of the day, states have been negligent, and states across the country. It's not just Texas, it's not just Florida, it's not just Georgia or Arizona. States have been negligent in expanding and increasing their funding relative to the cost increase.
So you're saying that it's not just these Medicaid expansion states that we're going to see, this is going to roll like a wave through many states, number one. But yeah.
Yep, absolutely.
Okay. And you said that these states are under pressure, and we have a saying in the hood, right? I haven't been in the hood in a while because I moved, but shut up, Dena. But pressure bust pipes. And and I think that's what I'm more afraid of, is that this thing will just go boom, and we will have people who will not be able to access medication. And what I keep looking into this and thinking that what people aren't thinking about is that a person without their medication for 2 weeks or 30 days really are at huge risk around being undetectable. And that's a big deal. It might sound simple in that, you can't get access medication for 2 weeks or 30 days or 60 days. You can get back on it. We'll figure out a compassionate use program, but maybe it takes longer than is a reason. Dena, I'm coming to you. And I think I really wanted to talk to you, and I'm going to get up to Lee in North Carolina because I know he knows everything politics in North Carolina. But I'm coming to you because I think you and Joey are our two kind of clinical direct. I know, Lindsay, I know you're at Legacy, but I think you do more of the policy stuff, not right. See, I'm trying to keep it all clean, right? Okay. And so, Dena, are you seeing more people come in who need access to ADAP? How are you seeing this ADAP thing in Texas play out on the front line? Because I don't do direct services anymore, right?
Sure. No, absolutely. And I will, I quickly reached out to one of our colleagues. His name is Stephen Vargas. He is actually on the conference call as well. And so if you see him, I'd like to ask him to help me answer, because one, I'm in a rural area, so my population is smaller in terms of the impact. And when this started to really happen and we talked, I did check with my team. They're not having issues right now, but again, we're small. But I would love to ask Steve to piggyback on that in terms of what he has seen from his work in a larger area.
So you just here for eye candy?
I am.
Okay, cool. I just
Happy
wanted to make sure
Tuesday.
I'm all clear about what's really going on.
Oh, and I see Cordella is also on there, so maybe she might have some ideas as well, just in terms of what that impact might be from groups that serve a larger population.
Okay, Steve, and then I'm going to go to you, Lee, so get ready.
Hi, folks. Sorry, came in from a jog, so and I saw the message from Dena to be on the call. So I'm a little. You see my hair, anyway. Let's see. So really, the biggest impact, at least for people living with HIV, isn't just that idea of not being able to get our meds. That's what's got people mobilized for sure. But it's really how this all kind of played out, and we came into knowledge. Evidently, the decision was made December 7th. A lot of people didn't really find out that folks were going to be, because of the way Texas was not going to be using its spend down measurement to determine eligibility for ADAP, that up to 2,500 people across Texas, probably a little bit more, would be rolling off of those rolls as of December 7th of 2020. But a lot of folks didn't find out until January. I believe one of the pharmacists, if I remember correctly, that serves on the Reinhardt Planning Council was sharing that some folks weren't finding out until they got to the pharmacy and were trying to get their meds, and then they discovered that, hey, you're no longer eligible for ADAP. And they started working plans so they can get access to the meds, other plans to do that. In a large urban area, we have a number of resources for folks to go to in case something like this happens. But the resources for up to, I think for the Houston area, I think it was something close to 200, 150 something in that range of folks who could be directly affected by this change. So being able to encompass all those folks based on how much money we put into those categories to help them out last year for this year, I'm not sure if that was going to happen. And so that's a situation right there that a lot of folks here were surprised to find the news. Even some of the providers that are funded by the state were surprised to find the news, and we're scrambling to figure out ways to help people. What I mean about the HIV community, and that's not the only problem about the meds, that's certainly the life-saving one. But the other one is that the way we found out. We not a notice, we just go to the pharmacy, and all of a sudden some folks found out that they're no longer eligible. Where was the communication about this? We had received communications at the end of December 2019 about some of those eligibility requirements that were put in place because of COVID to facilitate renewing their eligibility were going to be removed as of December. So we had all that information, but not once was this shared in some of those communications. So that was a little surprising and disturbing.
Okay, I'm gonna come back to you because and then Joey, I'm gonna come to you, but I want to go to Lee first because I want to get him in, and then I'm gonna come back. I got a plan here. I got a plan, people. All right, Lee, go.
Yeah, I think the high level is that, North Carolina's program in terms of funding is in a stronger state than a lot of the other examples that we've heard. Our organization significantly helped increase appropriations for our state's ADAP back in 2011, 2012. We were at crisis point. Folks may remember there was national news that our program had some of the longest waiting lists in the country, some of the strictest eligibility standards. And so I think because of that history and those significant appropriations so many years ago, the program's been pretty solvent. We were also a late adopter of moving folks onto premium programs and have been doing that at an increased level over the last couple of years, which traditionally has brought in better rebates for the program as a whole. So I think, we're in a pretty okay place now in terms of the appropriation, but I think everything that everyone's talking about the long-term, increased enrollment due to COVID, sort of the impact of not having Medicaid expansion does have me concerned that, in 2-3 years, are we going to be having to have some similar appropriation conversations that other states are having like this year?
Right. So I want to say two things. One is that, RHSPN, CEG, we've met with HRSA, and HRSA has basically said to us, there's nothing to see here. There's nothing to see here. There's no problem. There's no problem. There's no problem yet. And whatever your issue is right now is a state's issue. It's not a HRSA issue. And I disagree with it because I think that this is a planning and preparedness issue. This is a community engagement issue. I think what you were saying about kind of whether people showed up without having access to medication unknowingly, when is this going to happen again? When will it happen? It's like, Lee, you're saying 2 to 3 years, you need to keep your eye out, but we need to be educating the populace about there are chances or opportunities here to be thinking and planning about what you're going to do with your healthcare. Because one question I just got from out of the chat is, how does the interruption of HIV medication fit into the federal initiative to end the HIV epidemic, right? Which is kind of like central to it, right? So the central theme of the entire, ending the epidemic plan is that we want to keep people what? Undetectable and untransmittable, right? That's the whole goal. And if people can't access medication, then that kind of disrupts the entire system. Joey, I'm going to go to you, then I'm going to come to you. Jen, I saw your hand up. Did I see somebody else's hand up on the panel? All right, go ahead. So Joey,
Okay.
and then
This is
Jen.
going to be a first, and a couple of you might faint, but I understand why HRSA told you what they did, and here's why. Because in the Ryan White policy from the very beginning, there was an expectation that local areas would be reprioritizing when needed based on changes. So Florida doesn't get it right very often, but on this one, we got it right, especially after the last time we had a wait list when we had 10,000 people fall off and had to get them back in. We instituted the sweeps process at the local level, at the state level, and with our Part A's, where every quarter you look at utilization versus what you funded people for. If they're not utilizing near the rate they're supposed to, they reprioritize those funds to go to the services that are utilizing or overutilizing so that the money gets expended and services that are in greater demand get funded more. Secondly, insurance benefit management, the cost benefit analysis, 10 different states have shown it's smarter and your dollars go further when you do insurance premium support. Florida has maximized that. We have just as many people on insurance premium payment now as we do on traditional ADAP. And then last, where's your Part A buy-in for those states that have more than one Part A, so that in times of great access, especially from urban areas, that Part A's have unspent money that they could reprioritize to ADAP funding, so that there's a mechanism to address this if it's a blip. And again, like for Florida, we figured out a way that for this year we're good, and for next year there's time to reprioritize Ryan White Part B dollars. But I've noticed many states don't do that. Like when you say that an ADAP hasn't increased its line item in 5 years, something's really wrong in the planning process. So maybe these ending the HIV epidemic dollars should have new planners involved, new statisticians, new people to help them get out of the politics of turf protection and into data-informed decision-making, where you look at utilization, you look at the funding, and you figure out some money's got to move around, folks. And some lesser priority services may need to be reduced, not the ADAP, because what typically happens with bureaucracies at state levels, close down the ADAP program, lessen the enrollment, lessen the formulary. That's exact opposite of what it should be. It should be, where's unspent money? How do we figure out how to leverage stuff? Let's scour to see if we've got active Medicaid or private insurance, or let's do interventions with case managers to see who's got a partner with private insurance that we can get the spouse on. There are lots of avenues to increase capacity instead of shutting off ADAP and disenrolling people.
So I'm gonna ask you two questions. One, I want somebody on the panel to answer for the question, or the why is this important? Why is it important for folks to be able to access their medication, and as it relates to the ending the epidemic plan, and for on an individual level, but I think also on an organizational and state level. And then I think the other part of my question is, so is that the job, Joey, of the state? Is that the job of this kind of parsing out how we are going to find what options are available, new tricks, new moving money around? Is that like community supposed to do that? Is that the state health department supposed to do that? Is that the feds are supposed to do that? Is that Tim Horn at NASDAQ supposed to do that? I just busted him out. I know he's on the call. And so, who's supposed to do that?
If I can respond briefly, if you look at your policy and your programmatic written in stone from HRSA, local level planning councils and consortia should be doing that. States should be doing that with their state level community planning bodies. So every state should have in place those kinds of groups that bring together all these different kinds of people to say, something's got to give, something's got to move around. And if money's not being spent, put it in a priority area, particularly for ADAP, when that deals with both prevention and patient care now. You're talking about treatment as prevention, U equals U, as well as quality of life and keeping people as healthy as possible and undetectable for their own personal benefit as well. So it tells me this is what we should have been doing all along, but now more than ever, all of those different functions should be activating now, because we're all seeing ADAP surge, whether we know it or not, in some of the other states.
Right. So I guess, I mean, yeah, Dena, because I'm going to come to you because I know you've been engaged in community planning since Hector was a puppy and he's a big dog now.
Hector's old. Hector old.
Right.
Hector's
And
so
so
old.
that's my question. Do community planning bodies who, I mean, I think in most jurisdictions, they're merged now, prevention and care, right? Do they have the gravitas in states to make this happen? That I think that's one of the questions. Do they actually have the power to do this? Dena, I don't know if that's what you were going to say. And then Jen, I'm going to come to you.
Sure. Well, I think, you know, and one of the things that's happening here, how I ended up kind of, you know, participating in this, one, just as an advocate in on both sides of the track. I run an organization and living with HIV. So kind of, okay. And so what we're looking at, I feel like I'm dealing with two issues. The state called and said they want to have a town hall meeting. We're going to come together and we're going to talk, right? Well, that's cool. But before we do that, I'm going to, you know, I have to naturally have a conversation with the community. And one of the things that we're working through and I have some concerns about is the frustration of the committee. It is the case managers and the staff that's getting the call from the patients. They don't know what to say. They're trying. That process of being removed from decision-making, removed from the conversation around is happening in that preparation is what led us to that place. But then we're told, you know, in preparation for the town hall that we have an Texas HIV medication committee and they're supposed to, and we're supposed to. Well, if everybody is supposed to, how come nobody did? And we're here. And so I think part of the conversation is acknowledging that we kind of got to a crazy place, but legitimately, how do we reestablish? And I think like Joey says, you know, we may have to come up with a playbook of how this works so that if we have several years pending of, you know, of some, turbulence, that we're all a part of the dance. Because I'll be honest, as an advocate, you know, yeah, this is horrible, but as a administrator, my first question was, where are all the dance partners? Did everybody dance? Did everybody bring their shoes? Was we all tapping or no, we weren't? So what happened? And that's part of the exploration. Because I'm sure like everyone else, we have our up and down relationships with our funders and our feds and our states, but we bend, we don't break. And I'd hate for us to get to positions where it's most critical, where we're bending more than we really should, when we could be working together. So that's kind of the role Stephen, Lindsay, and I will be playing at our town hall meeting, which is damn near at the end of the month, kind of almost beyond the point, but we are coming together to look at how do we move that forward and to reinvigorate advocates to be a part of all the different processes, especially during this trying time. Was that a better cute answer?
That was a cute answer, but it didn't really answer my question about whether or not community planning bodies across the United States today in 2021 have any weight. Lindsay.
Well, yeah.
Well, what I will say is the way that the decision was made around ending the spend down, it was made in a vacuum within the state. For instance, my physician at Legacy is the chair of the Texas HIV Medication Advisory Committee. And she wasn't even made aware that this change was going to take place. We found out on December 29th by email. So, that's a really bad day to announce a major change where 2,500 people. So that's actually how many people would have been affected by this change, would have been kicked off the program. And that was already effective December 7th. So they announced it to the community on December 29th. It was effective December 7th. So we were able to, by a lot of advocacy, And I mean governor's office, lieutenant governor's office, speaker's office, elected officials, folks that would be affected by this eligibility change, calling elected officials. We were able to get it stopped until June 1st or May 30th, as y'all were pointing out. But this was absolutely made in a vacuum. And so I think that the state learned a very valuable lesson, that you cannot make HIV policy in a vacuum. And I do think Joey's point about insurance subsidies and looking at new ways, especially while we have open enrollment right now, is incredibly important. And so, Joey, your explanation of how Florida does it, I have it right here. Call Joey after this meeting, because if I can map this out for the state on several different avenues, not just ADAP, I think that's going to be a really important thing. And in fact, the state does have some insurance subsidy regulations that are out right now to comment on. So Joey, I think we're all moving in that direction, but to be honest, who was running the state of Texas HIV program was moved to do vaccine distribution. So someone new came, and I just don't know that they completely understood the power of this community. So Toni, I actually do think we are an extremely powerful community that can make policy, but it did take a little advocacy on the front end to get to just let them know how strong we actually are. I will say that for Texas.
Right. Jen, you had a question? You had something? Yeah.
Oh, I have so many feelings. And Joey's very familiar with my feelings. It's one of the beautiful things about hormone therapy. So part of the issue here is that on the local level, in Florida, we've got great relationships with the state level. They're amazing. Even if there are issues beyond their reach, they're amazing in terms of responding to advocates, being engaged, taking feedback, incorporating feedback into planning, all that. On the local level, not so much. And that's not just an issue specific to county health departments in Florida. We've got administrators in New Orleans that just on basic policy issues, they're like, yeah, we got the advice. We consulted the community. That's what the statute requires us to do, but we don't have to do what the community says we need to do. And that's an issue. That's a statutory issue. If the statute read that these planning bodies and the administrators have to significantly and meaningfully incorporate the feedback and contributions of community, it would look very, very different. I think our planning, would be much, much further along than we are now. I want to address how does this deal with EHE. That's been super effective messaging in Texas, some in Georgia, in big ways. Is that if we're going to meet these needs, this goal of ending the HIV epidemic, then we have to make sure everyone's getting their medications. There's a potential for repurposing, and Joey brought this up with treatment as prevention, repurposing some prevention funds into treatment because it does act as a prevention activity, making sure people are engaged. Who's dropping out of care? Like really narrowing down. One of the things that I've seen missed in not given nearly enough emphasis in every single EHE planning meeting I have been in, and that's in many states and many local jurisdictions, is this emphasis on retention and care and meeting those treatment goals to reduce community viral loads, to reduce the incidences of new diagnoses and transmission. We're not there. We're all still in crisis mode going, oh my God, how do we test so many people? But we've got to take that next step. And we've got to take that next step in our advocacy. And we've got to get creative.
And maybe we can talk about this on a state level or state based, because I've got two questions that have come up. One, what are insurance subsidies? Who wants to take
Are we
that?
asking that generally, or you want me to answer?
So the general question is, what are insurance subsidies? You've each spoken about insurance subsidies, and I believe that they're different jurisdiction by jurisdiction. But so I think what are they in your state? Talk about, if you take 2 minutes and just talk about what the insurance subsidy plan is in your jurisdiction as it relates to ADAP. Lindsay, you go first, because this is all your fault.
Okay, I will try my best to answer this, but we are a Ryan White state contracted provider. Legacy is. We are, I think, the sole provider within a 13 county area where we actually use the funds that are provided to us by the state and HRSA to help get people insured, essentially. So we use the Ryan White, I think it's Part B funds, to subsidize people being fully insured, which is a great thing for them. That way their medications are covered as well as all of their medical visits. So it's not just the ADAP program. So I want to say we might be the only one that's doing that in the state, but they're trying to open that up. And Joey, you can help me explain if this is how your state does it as well. But the ultimate goal is to have an insured patient at the end of the day.
Okay. Lee, stop playing, stop texting on your phone. Tell me about insurance subsidies in North Carolina.
Yeah, I mean, so I alluded to this a little bit at the start, but our state has increased its support of getting folks on insurance on the ADAP program called HMAP in our state over the last several years. Our legislature approved the ability for the program to provide subsidies for folks, both premiums and medication co-payments in 2016. Honestly, that was behind a lot of our southern peers, like Tennessee, Virginia, and South Carolina all had programs in place before we did. But that program was rolled out in about 2018 after legislative approval, and some income restrictions were lifted on it this year as well. So at this point, I mean, it's certainly going to take a lot of time, but we're playing a bit of catch up to get up with other states in terms of having more people on insurance programs than just the medication program.
Okay, Joey?
Yes, we had the largest AIDS insurance continuation program for decades here in Florida, and we modernized the program. It's now called an insurance benefits management program, and we use the litmus test that the HRSA requires us to ensure that it costs no more than it would if we provided the medication itself. So we have a medication access committee on the statewide planning body that reviews all of the Affordable Care Act plans to have an ADAP approved plan that you can be reimbursed as a third-party adjudicator, so they pay on behalf of the client. We have a very sophisticated contract that I'm going to share with Lindsay that the state has to put out to bid for that insurance benefit management function, and it allows for a provider who's not a medical provider to be able to be the third-party adjudicator on behalf of the state for all of the ADAP funded insurance plans. So it's saved a tremendous amount of money, not quite to the level that the old AICP used to get. For every dollar you spend, you save
AICP?
$3.
What's
AIDS
that?
Insurance Continuation Program.
Thank you. Thank you, Joey.
Yes, I'm normally the acronym police, so
right,
thanks
I mean,
for
for the kids that are in the back of the room, right?
Right. So basically, the benefit is it does more than just pay for the medication. It provides an insurance environment for people that allows for medical providers to have more selection and more types of providers that typically would not be in a Ryan White contract environment. So it helps with capacity with additional providers. It helps with freedom of choice for clients to pick a plan that allows them to get more and do more and have more choice in their care. So it's a win-win situation, and it saves money for the state as well. You get more people in the insurance benefit program than if they were simply going to the traditional ADAP program.
Got you. Okay. Dena, do your team have anything to add to that?
No, we actually, because we're not very active. We used to do ADAP, but we don't actually our direct link anymore. So I'm gonna go ahead and just still be cute on that question, because we don't do a lot with insurance premiums.
So
but I am listening, because that's
tilt your head and go back on mute. Jen,
right.
You have anything to add to that?
I got to make sure I got my unmute off on all my devices here. So thank you for the pause. So one of the things on that is make sure your scoring is proper. If y'all are going to be active, and if this is not something that's actively involved in your state ADAP design yet, because program design, then make sure you're paying really close attention to how you score those plans.
What is that? Talk, come on now. Come on. It's not
Find
that body now.
how you find the value in the plans. And I bring this up in particular, Joey's laughing his rear end off because that's how he got me involved in the first place, was scoring the plans for Broward County for the first year of enrollment for the Affordable Care Act and where Ryan White and ADAPs were being involved. So I paid attention. Here are the metrics I recommend. Paying attention to your provider network, drug coverage, how quickly those things are adapted when there are new medications out, preferences over like for brand over generic every single time. And I know that there's a huge fight over this, but generics, there are problems with generics. Yes, they perform to a certain level, but there's a great deal of conversation happening right now as more antiretroviral therapies are moving to generics as a cost-saving measure. When we move people off their preferred medication, or when we see networks narrowed when it comes to providers, we see people drop out of care. We see people stop taking their medications. We see disruptions in care. And the entire point of an ADAP is to reduce those potentials. If we're not reducing that, then we're failing our job. So the big things there, your provider network needs to be as wide as possible. You need to make sure you have at least 3, and I mean this, 3 infectious disease providers as primary care and accessible to a client in each of those plans.
Why do I need 3?
Because you're going to find that clients, if they're new to the network, they may or may not mesh with the provider. You're going to find that clients move quite frequently. And so where they're geographically closest is going to matter. You're going to find that clients have disruptions in their life on what they're relying on, because if they're already on ADAPs, they're already in Ryan White qualified, they're already asking for help in the rest of their lives to meet their needs. This is just one of them, and we've got to be as flexible and adaptable as possible.
Right.
So make sure
Tim
that
Horn, I see that you put some link in our chat. What was that? What was that you put in there, Tim Horn?
That's just the policy clarification notice regarding to the premium and cost sharing assistance service category covered under Ryan White and ADAP.
Okay, so you gave the people some information.
Yeah, it's just to support everything that's been said already.
All right, I just wanted.
That was the litmus test that I had referred to.
Okay, and so Tim, now that I got you on camera, I tricked you. Tell me, I know that NASDAD's role is really the health departments. I got that. But if you were to say, if you were in your old job, what would you be telling community advocates to do and say and work on and prioritize right now?
Yeah, I think it's the community engagement that's been discussed, thus far is absolutely critical, and just making sure there is community engagement with certainly on the state level with the ADAPs, certainly with the Part B staff, just to really get a clear sense of what's going on. Because I think just sort of in addition to some of the, Lindsay has, Lindsay elegantly laid out, some of the situations, that are occurring in Texas. And it's really, there's a whole lot of stuff. I mean, it's just not about, the particular sort of, those who are, they're being moved out of small and large group plans and onto, full pay programs. But even within, the ADAPs, even within, Medicaid expansion states, it's like what's happened is, you've seen a number of folks who have moved out of small and large group plans and into Medicaid. And what happens there, you think there's not going to be an impact on that, but just because of the way the different rebate structures, actually work within an ADAP, that can actually have a potential impact on, the ADAP bottom lines. It can have a potential impact on their budgets because it's going to change a lot of the rebating on that. And also, I think some of the points that have been happening around what's happening in the insurance space. I think that, Joey's spoken to this, and Jen and Lindsay have spoken to this in terms of, it's just certainly with the premium cost sharing assistance, all of that, it does need to be cheaper in the aggregate compared to somebody being on the full pay program. But what's happening there, particularly in the insurance space, is that we do see premium costs are going up, we're seeing cost sharing that's going up. So, so no longer is it like, like co-pays of like $25 or $50, per month. What's happening is some of these are actually moving into the specialty tiers. So we're seeing cost sharing that's around 20% to 40% off of that. So that can have a significant impact on ADAPs. In terms of like their bottom line, and so that's going to affect their expenditures. It could potentially impact the sort of like the rebate revenue that they have, which is really important to not only ADAP operations but also to feed back into Part B to support those service categories. So there's a lot of stuff that's happening there. So what needs to happen is there does need to be a good deal of really just like conversations between the communities and between the ADAPs and the Part B programs.
Okay, thanks, Tim. Cordelia, you just put a question in the chat about rural communities facing a different set of challenges. Do you want to come on and pose that question to the group, or do you want me to just read it out of the chat?
Hi, I knew Toni would put me on the spot, but thank you so much. Rural, of course, there are two different, types of rural. Are we talking about location or are we talking about population? But in the general sense of the word, there are many rural communities that do suffer from identifying specialty providers. It's not just with HIV, it's also with mental health and other conditions. So for the previous provider, I do understand, and of course, I know what it is like when patients have a choice for who they see as a provider, and it is a valid point, but many communities do not have that choice because it's so hard to identify providers, even in this age of telehealth. So it's not to discount that comment, it's just to expand on what rural communities face on a daily basis and the challenges that would arise from that.
All right, Marcus wants to give a quick update on West Virginia about this also. So go ahead, Mark.
Hi, for those of you who don't know me, I am Marcus Hopkins. I'm the operations manager for CEG in the RHSPN. And to speak to Jen's point, and actually to echo what Cordella is saying is, West Virginia is essentially a rural state almost in its entirety. The state of West Virginia currently has 2 active Ryan White clinics, one in Morgantown, West Virginia, and one in Charleston, West Virginia. And between that is a 3-hour straight travel. Everybody who's in the central part of the state has to travel more than an hour and a half to get to one of those 2 Ryan White clinics. Yes, there are occasionally options where they can meet an infectious disease provider somewhere in the twain, but those are few and far between. In West Virginia, one of the things that we're seeing is that as of December 15th of this past year, of all of our new HIV infections in 2020, 72.3% were related directly to injection drug use. And nationally, that percentage is 7%. And when we're talking about people who inject drugs, we're also talking about a population who is going to have to utilize ADAP services, even if they, even though we are a Medicaid expansion state, because of some of their issues, they may not qualify for Medicaid. So, it would be a dream to be able to have 2 or 3 different providers available, but I just don't think that's a reality in most rural states.
Right. Thanks, Marcus. We have one other question, and that question is, so does this mean that it's time for HRSA to remove the state administration of ADAPs entirely? Oh, don't everybody get quiet now.
This is Stephen, Toni, in Houston. Y'all may have seen.
Motion to approve.
Yes, exactly. Same here. The difference right there, Part B and Part A.
Hey, Stephen, can you either get closer to the microphone or?
About that. So you can hear it better now? That big difference between Part A going to cities. The only reasons Houston has that capacity to pay for health insurance to get people on there is because our local planning council made that decision to do it. Metropolitan areas get Part A funds can do that. It's that Part B where people living with HIV that serve in the state advisory boards or whatever they're called, that we're serving in that advisory role. And just like was mentioned before, we can let them know what we'd see as the best thing that could happen and what we could do for the best outcomes, but they can always decide to ignore it for whatever reasons. And say that they spoke to the community, received their input. One of the things I was thinking that what you just mentioned is, yes, one of my frustrations with Part B sometimes is exactly that. When you have people living with HIV, seen with the folks in those urban areas, and we decide that, hey, it is more cost effective for us to buy insurance for folks, it makes sense for me. I think could possibly work at the state level too. If you had people as part of that decision-making body instead of just advising, we could make an impact there too, and probably avoid some of these crises. One of the crises here in Texas was they did not use their Texas HIV Medication Advisory Board, as Lindsay mentioned, to even vet what could be done. I tell folks, we would not have put 2,500 lives on the chopping block. We would have looked at everything else but that. And if it came to that was the only choice, we would have opted for what they did now, which is, let's wait. Let's tell folks now, give them 6 months to prepare, find some other options for folks. And so that was the appropriate way. And that's what they chose to do now after we raised the ruckus. So I think you're right. Part B, let people decide.
Hey, so, one of the things, I'm coming to you in a second, Joe. One of the things that I kept asking myself was, with all of this, right, with all of these challenges in Texas and other jurisdictions, who's paying for who's paying the extra money for the providers that have to do all of these extra steps? Because now the case manager, whether it's a medical case manager or not, has to do like 2 or 3 or 4 or 5 or 10 more steps. And so where's the extra cheese for that? That was the part I kept missing, even in the what I call the Texas solution. I was like, well, wait a minute. People still have to do this other work to find patients and clients. You have to make some phone calls. You then are going to have to find either compassionate use programs or other. So that's I got people with a caseload that was probably already a burdensome caseload, I'll call it. And now you're asking that I have to come back and backtrack and do all this other stuff. So did y'all get more money out of these Ryan White COVID funds that would allow you to add on either staff time or new staff or something like that? I know the answer is no, but I just thought I'd give you an opportunity to say no.
Dena might know from an administrative standpoint. We did receive CARES Act funding for being a community health center and things like that. I just don't know if we received direct allocation associated with ADAP program and case management. But that would be a national thing. So I guess any of the CEOs could answer that. I will say we do have a really strong LPAP, so local AIDS pharmaceutical assistance program in the Houston area. And what's what we're aware of is that, okay, so if everyone got kicked off of the ADAP program, we could depend on our LPAPs in Houston and the larger cities. But if you are a very rural part of Texas, you may not have an LPAP to depend on. And that's actually who we were most worried about. It wasn't necessarily, the individuals that we serve at Legacy that we were most worried about. It was more statewide that this could become a very big issue for the really rural areas. So I do know that option was there for us to help us. But maybe one of you can speak to whether or not we received direct allocation of CARES Act funding. I know this, just to let you know, last Friday, we had reached out to HRSA to ask them to clarify to the state that because of job loss associated with COVID, that we could use some CARES Act money to fill the gap and hopefully get us whole for this year. We did receive word on last Friday that they did receive funding from CARES Act that was for an allowable use for the program. So we were able to get that clarification. So I don't know if that's going to go to just the ADAP program or if it's going to go to case management and other Part A and Part Bs, because now we're looking at potentially some prevention contracts being cut. So it's just a really difficult situation right now. But there's also going to be what's called an exceptional item in our budget because we're in session right now. The budget is being decided. the state is going to ask for a fairly large sum of money to get us through the next biennium for the next 2 years. So I do think we're going to be made whole. I just think we're in sort of this weird CARES Act funding gap until we get the budget sorted out. And I actually think that's why they put a limit on not implementing this spend down approach until June, because that way the budget will be worked out by June.
Right. Did you have your hand up, Lee?
Yeah, I thought it was just worth, I joked in the chat that Toni sort of threw this bomb out about the idea of changing from 50 ADAPs to sort of like a universal program. I mean, I do think it's interesting, but I feel like I don't want to lose that moment because I think we're all sort of like crippled to like respond to that really quickly. Whether or not, I do think probably given the structure of all of the other programs that exist that are giving low-income individuals access to health insurance or things like that, like I wouldn't think shifting to a national model makes sense, right? Like I think that would have been a really difficult conversation during certain Republican administrations. You have state governments who are putting money into these programs at various levels, of course, but like you probably lose that. There's such changes in eligibility and who's on what type of programs from state to state that like it's certainly interesting to explore, but I think there's probably a lot that's actually lost with some kind of a shift like that. So I just felt like we needed to like not leave that hanging out there. I would expect, right, like there's been conversations for a long time. I know, years ago about Ryan White reauthorization, like that really got put on pause during Trump. I feel like that might come, I would assume some national advocates are thinking about broader changes, and we have some new opportunities nationally just to think about funding and infrastructure with this new leadership in the House and Senate.
Cool. And Joey?
Just very quickly, I disagree with you on this, Lee, because I think the economies of scale for a national ADAP program would far outstrip things, and maintenance of effort, those states would have to keep that money to stay in the game. There's a way to lock in what they have. But back to my original point that I wanted to share with people, because I know a lot of people say, oh, Part B's advisory, we really don't have any control. The language says, if not, why not? So if your local community, your state body says, do this, and the state wants to do something else, they have to put in writing and justify and have a data-informed decision-making process to say why they're not going to do what the community wants. I have filed complaints and protests with the federal government. Much to my surprise, they supported and advocated for the community response. And we had some administrators and some bureaucracies that people found new jobs and got removed. So there is still power in the community to say, here's what we came up with. Here's the process we used for it. You should be doing this. If not, we're going to file a complaint with the feds. And the advocates need to know that and need to do that so that the bureaucrats understand they're working to manage our money for us, and they have a process that they have to follow. But this is all predicated on the community. People with HIV, that's why this money is here. It's not the state's money. They're hired to manage our money for us. And so I always start with new advocates with that's the groundwork that we work from. Not that we have to go by their rules, because I've pushed back, I've fought, I've threatened our state bureaucrats that not one person comes off our ADAP program or we come after you and we come after your job. That makes them listen and pay much more attention. And I think some of these other states, you've got to kick it up a notch now, because if you don't, they're simply going to say the easiest thing for me to do as a bureaucrat is to simply cut off the enrollment or throw some people off a program instead of moving money around, because that causes paperwork and people to have to do work. So there's no love lost between me and state government. I hate it. I think our ADAP programs are incredibly inefficient for 2021. To have to still be fighting for electronic registration when state Medicaids have all moved to that. Local government doesn't work for a program like ADAP. It needs to be national. And if nothing else for reauthorization, they need to make pharmacy work like pharmacy does everywhere else in our healthcare system, not the brick and mortar model from the 60s that our state ADAPs currently do.
So we have it looks like a little difference of opinion between the UNC Tar Heels and the Florida, y'all the running rebels, right? And oh, that's not, I think that's Las Vegas. That's not y'all. Y'all in the gate.
The UNC Char Heels did pretty well at a basketball game Saturday night, Tony, in case you,
easy,
in
Turbo.
case you didn't know.
Easy. Don't bring up old stuff. Let's bring up the future. So here we go. David, you had a question.
Yeah, it was both a comment in praise of Joey's fierceness, because I think that is really critical. One of the things, though, that I found as being a community member or partnering with community members, especially at the state level, is some communities have confidentiality. So when I was on the Medicaid advisory committee in the state of California, I had to sign a contract that I would not share any of the proceedings of how people voted or what the discussion was. I could only share the outcome. Now, I'm saying this on this call, I didn't always do that because I thought it was really important for advocates and for people who would receive drugs and services in the state of California to understand how decisions were getting made and what some of the arguments were. And this was really particularly critical once the hepatitis C cure medications became available and decisions about whether and who to cover those drugs for. So I think that's something that also needs to be torn down, is any committees where there is supposed to be community accountability, having those committees be transparent is incredibly important. And I think the other part that I found, especially when state governments are the decision makers in large measure, is ensuring that the community folks that are on those committees are either connected to or part of organizations that have a strong advocacy component. Because if they're not, it's too easy for the administrators to completely ignore those community members. And believe you me, I've seen this at the city, county, and state level. You have people who have been in those jobs for 20 years that handpick community members and keep them on those committees for 10 or more years because those folks just don't challenge them. So I think that we have a responsibility to work within our own communities to make sure that the folks who are on those committees are actually able to do the work we need them to do. So.
Right. So does anyone have a question for our panel, any one of our panelists, or for the panel as a whole? If so, put it in the chat and I will make sure it gets asked and answered. If not, I'm gonna take moderator, facilitator license and ask this question, kind of following up on a bit of what David just asked. And this will be our closeout question. So make it good, because this is how people will remember you, Lee. And what are the planning pieces we need to be doing at the local level, state level, national level? What's our engagement strategy? What does it need to be for now? And I think that's the urgent response, right? But what's our strategic community engagement response and our strategic community engagement plan? Because see, I think that that's what we need. I said I felt like we needed a predictive modeling to say we could figure out where this was going to happen next. Kind of like, Doppler radar or hurricane planning, that we needed to be able to do that and figure out where this bomb was going to go off next. And so everybody's like, yeah, well, I don't know, because of this, because of that. But my question still remains, what do we do? What do we do to get other jurisdictions ready? But what do we do in the immediate? And how do we engage communities at a local and a national level? So that's a real question, and I want real concrete answers. And you can't just hang up the phone and say, oh, oops, my call dropped. I don't have a structured answer for you. The call dropped. Who wants to go first?
I mean, I can go ahead and jump in. I think, often I heard Lindsay say this when she was talking about their challenge in Texas, right? What did they do, right? They sat down with like the governor's office, the lieutenant governor's office, co-chairs of your appropriations committees, your health and human service committees, and your ADAP staff, your communicable disease branch staff. I think communities, folks leading HIV advocacy efforts on a local level, state level, they're probably about 8 key people, right? And I think, some elected officials and then some administrative staff at your Department of Health and Human Services. If you don't have a relationship with them, somebody in your state needs to be leading the work to have the relationship with them. And you need to be in regular communication about monitoring these programs so they know if there is a crisis that, HIV activists are scrappy, we're loud, we're going to get things done.
Okay, so all right, so wait a minute before you jump, Lindsay. So according to Lee, what we need to do is make sure that we know who these 8 key people are. Who are they? So I need to know who the ADAP coordinator, the Part A coordinator, who are they? Lee, specifically, who do people need to be talking to?
Yeah, off the top of my head, I think it's the person who's your state HIV director and their boss, whoever that is, likely within a Department of Health and Human Services, different states have different names. And then your House and Senate have a co-chairs of an appropriations committee that focuses on health issues, and then your governor's office. Okay. And probably the health staff member within the governor's office. And if you don't know the names of those 6 people, then you should know their names and build a relationship with them.
Okay.
I can interject?
Yep, absolutely.
Okay. Along with what he's saying, exactly right. But I think some of the states are going to discover something I discovered here in talking to some of these folks that they're mentioning, which is a lot of folks at the state and local levels were redeployed and doing COVID work. Part of that resulted in different leaders now. Some of those different leaders that I discovered I remember talking to Dena, we were both asking, who is this person that they're having at our meetings and everything else? We didn't know who this person was. It turns out she is now our ADAP stuff had been moved under her different leadership, essentially. What the thing is about that is this. That lent some understanding to me, at least, that, okay, our relations have been, pretty okay until recently. I attributed it to COVID, but then it's bleeding over into now. And so it's something else. And one of the things is that new leadership is educating that new leadership about how we got the programs we have today with people living with HIV being involved. When they cited some of the work in which they have people living with HIV involved, I shared with them that, yes, I was part of that. And the relationship we're doing now with this town hall is not the same process that we did with those other ones. So it's about educating them to let them know that these are our expectations for how things need to get done. Some of it's codified in law, which is going to help you do better. It's a form of calling them back in instead of calling them out, but just so we can work together and move forward. That's one thing. So be mindful. There may have been changes because of COVID, and some of the folks making decisions, and those folks making decisions may not be aware of our history.
Perfect. Thank you, Joey. I see you with a pen, so I know you're actually writing out your master plan. So there you go.
Okay, I have 3 critical bullets, but I'm going to start with the context of we need a point of contact for national ADAP policy. Maybe it's CEG, I don't know who, but someone needs to, for here and now, I'm sure Marcus could do this. Step 1 is a baseline resource inventory of who's doing sweeps process in the 50 states or the 52 jurisdictions. What's the state of insurance benefit management percentage of ADAPs? Like some ADAPs are at 50-50, some don't do any at all. What does that national snapshot look like in terms of how many are already doing IBM, insurance benefits management, and how many haven't at all and need to start? We need to create a 2021 ADAP 101 PowerPoint that can be shared with all 50 states advocacy networks so that they can share a standardized national perspective of here's what the ideal ADAP should look like and should do for your state, and not focus on the operational differences, but the outcomes and the outputs that those ADAPs do. Then we have I agree there need to be 6, but I think not just the political folks, because in some states the politicians are so far removed. You need to know the state ADAP director. You need to know the state AIDS director. But you also need to know the local level HIV point of contact in your local region, whether it's a Part A or it's a Part B area, because some states still have Part Bs with local consortia because they don't have Part As. So some are not combined. Even in Florida, not all of them are combined here. Next, industry support for webinars, like a quarterly ADAP get together like this, where people are talking about what's going on. We can share best practices. I've got a great state crafted ADAP insurance benefit management that I'm going to share Lindsay. Maybe there are others that need it. Maybe somebody else from another state's got the tool that I don't have and haven't thought that we need yet, so that we can start to share best practices and tools amongst each other. And then reaffirming that Ryan White policy expects reprioritization when needed, and that for these states that have a financial demand to expand their ADAPs, that they look at what else their Part Bs are paying for, what their Part As, if any, are paying for, and you need to move money around. Like a lot of areas, the money gets brittle and they keep the money whether they spend it or not, and there's just this turf protection instead of making the money flow to what's needed at that time. And then the Part A buy-in for a state. What's your strategy to work with your Part As? And there's your bulleted list. I'll send it to you in an email, Toni.
Don't send it to me, send it to Marcus.
Send it to Marcus.
And send it to David.
Send it to David.
Right. So Jen?
In terms of advocacy strategy, I think these are some really lofty goals, and getting folks in front of legislators are good threats to have in your back pocket. And I think what we're looking at right now, because we're dealing with two pandemics, our community deals with two pandemics at the same time, is people need food, clothing, shelter. Your medication comes last. If I can't keep the lights on, if I don't know where my next meal is coming from, if I can't take my meds without food, like, there's issues. So if, regardless of where the funds come from, I don't care. I really don't. That needs to be a priority for entities providing any level of care at all. Make sure there is wraparound connection and meeting those needs. Far too often, care providers miss that spot because we prioritize medications. We need to be advocating for the funding to link people to other services and resources. The other piece is for our care providers, carve out advocacy money, have a position. That person needs to be engaged with your clients. They need to be checking in. They need to act like a peer on the client-facing level and establish and maintain those relationships in community. Not only is this critical for engagement and care and making sure people are retained in care, but it's also critical to be able to say, yo, some nonsense is going on and we need you to get on a phone. Make it happen. I don't care if you go to a private funder to make sure that you're funding those positions, pay them well. Hire from within community. There are some base level things that we have skipped a step on. If you are hiring from outside of your affected community, you are failing your job. ADAPs are only effective for people who aren't making money. So make sure that your community is making money, and you can do that as an employer. I don't think we can look at these drastic policy level changes if we're not meeting these basic needs that are being forgotten and left behind. And it feels like an enormous task and haul. But if you want to be able to call up 100 people, 200, 400, 500 people to go to your state legislators and to go knocking on doors, then you've got to be able to do this. And God bless it, this is my thing against federalizing ADAPs. You know how hard it is to get enough people mobilized to change federal policy when it's not going the way you want it to. So that's my bit.
Thanks, Jen. Who's next?
Can I tack onto that as the person that is hired to solely represent the community within my organization? I cannot say enough, Jen, about that. James and I are both, I don't know what, Legacy is amazing in the fact that they have us on the ground. I'm in Austin. I live in Houston, but I'm here in Austin during the session because it is my job solely to advocate for this community and the other communities that we represent. But my last 2 months, James and I have only done this sort of process with the ADAP program. And I very much feel like Prism in Dallas has the same sort of thing with January Leo. If you've ever worked with her, that's our sole mission, is to make sure that there's no major changes to this population. And so I can't say enough about how actually effective it is to have a full-time person that just organizes people all day long and just talks to not only the head of the ADAP program, but the person that the ADAP person reports to, the person that person reports to, right? So I think that was Lee's point about, you know, when we started engaging governor's office, lieutenant governor's office, and everyone on what's called Article 2, which is where all budgetary decisions are made within the state of Texas around healthcare. So I think for us, at least from Legacy, there's a two-pronged approach. We do a very much a grassroots approach. So James Lee, who's on this call, but he organizes just the HIV Day at the Capitol every year. So we have a good 70 HIV advocates that meet every single year, and we've started organizing them very early this year, just because of the fact that we knew this was going to be a really rough year for all things HIV policy. And so I can't say enough about having a dedicated person within the state to really just organize advocates day in and day out and provide updates, and then do the HIV Day at the Capitol. It's been really helpful. And then the other thing I'll say, Toni, you know this, when I was between a rock and a hard place and I didn't know how to get to HRSA necessarily on this, I went to AIDS United and I said, help me. And they had some really high level contacts that I was able to get in touch with, that were able to talk to my state as well. So I think involving the national groups, being involved in a group like this is really helpful. I mean, I would have never met Joey, I don't think, and he may be able to provide for me some solutions that our state could look at. And so I can't say enough about having both the grassroots and the grass tops approach to doing advocacy.
Perfect. Lee?
I feel like I kicked it off.
He's back on the spot. Yeah, he did kick it off.
Right, Steve?
I agree with everything everyone said.
Oh my God.
Except Joey. I always like to fight with Joey.
Oh my God.
I wrote down almost everything Joey said because I thought that was really important stuff I wrote down almost everything Joey said. I thought that was some really important stuff for us to look at here in Texas for sure, at that state level for sure. And really my bit was the beginning. It's just to make sure that we know the leadership, because it could have changed because of COVID, and it might be continuing on and off COVID HIV as people are redeployed to address the epidemic. So being cognizant about that too, so we can make sure the folks with whom we communicate the message are going to be the same folks that are going to be making decisions, because that could change.
Thanks. Hey, Tim Horn, I'm going to let you tell us what you think your community advocacy partners, I know you with the state, well, what do you think we should be doing, and how can we support what's going on or what you're seeing?
Yeah, I first I just want to underscore everything that's already been said, and I think that the one thing, one area where NASDAQ is particularly poised to do is I sort of want to circle back to a point that Joey referenced in terms of insurance benefit management, and knowing like what's happening there in terms of what is the utilization, how are programs actually, how are they actually operating in an incredibly dynamic, sort of space. So I think that one way, that I think we can potentially leverage NASDAQ, and I think that one way you can potentially leverage our, Part B and ADAP like monitoring project is to, I think we need to sort of circle back. And I think what I want to do over the next, several months is I want to engage with a number of folks here to find out what are the data that are needed, not so much like for, the ADAPs to understand how, other ADAPs are operating, how Part B programs, are, I think we need to figure out like what do all sort of stakeholders, actually need in order to do this, including the community advocacy. And that starts with information. And it starts with understanding who's doing what and who's doing it effectively, and where are their challenges. So it starts with the data, right? And I think that I don't remember who brought this point up, but this really does need to be data centric. This does need to be very evidence based in the approach, particularly when you're thinking about what needs to happen on a national level around this. So yeah, I think that. I think there's a potential here for NASDAQ, and I think particularly for NASDAQ working with, a lot of community folks, particularly, in this group here, is like let's leverage, I mean, the data gathering that we can do in order to really strengthen, that engagement and what that looks like.
Can I just say one more thing, Toni, that I've found to be so effective? You're on mute, Toni.
It's all your fault, so you can pretty much say whatever you want to say. You started this nonsense.
Strangely enough, a lot of legislators in Texas just don't think HIV is a thing anymore. They're like, what? It's still a thing. And so the 2-second thing that I use is that 4,500 people in Texas are diagnosed a year with HIV. It's 12 a day. And then they're like, oh, what? So if you have a stat like that you can use for your state, I know that sounds so simple and basic, but I have found that to be, even the most conservative members in Texas have been like, 12 a day? I'm like, yes, this is very much still a thing. So I don't know if that's helpful at all, but that has been like the catchphrase that I have used over and over again to get people to care about it. And it seems to have worked.
And just on top of that, I think thinking about, the big high level numbers is that there's, if there's no understanding in terms of that, yes, the HIV is still very much a thing. What there is very little understanding is of how significant the Ryan White program is. A, B, C, D, ADAPs is, to people living with HIV, particularly in states that have not expanded Medicaid.
Exactly. Yeah, I can't say enough about how so many legislators just don't realize it. Some are on point. And like Lee was saying, there's like 8 people generally in a state that just get it. And those people have been just remarkable during this entire thing. But I've had to meet with everybody, and trying to get folks to understand just the sheer breadth of the program has been a challenge, but also really rewarding because there's just so much education to be done.
Right. Hey, Cordelia, I'm going to pick on you one last time because I come to you for our rule specific. What do we need to know and what do we need to do?
I think for rural communities, one of the big things we find is education and awareness. A lot of the discussion is sometimes held in the big cities, and rural communities need to be more engaged. They need to know more about what's going on. And sadly enough, they are most impacted because they are more disconnected from healthcare. I think one of the things we need to do is utilize technology to reach those people where they are. Are we doing something like this is fantastic. Are we on social media and getting the right message, accurate message out to the people, letting them know what it is and how it impacts them and how they can get involved? Because the disconnection puts so many of those people in a situation where they're the last to know, the last to react, and with very little resources to do so. So I'd like to see more engagement on that end for rural communities.
All right. I want to thank Joey. I want to thank Steve, and I want to thank Lee, and I want to thank Lindsay in my very electric company way. I think it was the electric company. I do. And I want to thank Jen. I want to thank Tim for letting me pick on him, Cordelia for letting me pick on her. I just want to thank you all. I think, like I said, when we started this, I think that this is something that is what we need to be looking at as a predictor. I also think that this shows that we do actually work well together. This is not a divisive topic, but I think something where we each have a little something to give to the solution. We'll be putting out a paper. David doesn't know that, but he will be putting out a 1 or 2 pager white paper on this call and some solutions and how we think we can work together. So we'll probably be reaching out to you, Tim and Joey and Steve and Lindsay and Lee and everyone. So again, I just want to thank you all for taking time out of your day and schedule to do this and to educate folks around the country and in rural communities across the United States. On behalf of myself Gabe Maldonado, the Rural Health Service Provider Network, and CEG, and True Evolution. Thank you. Have a great week, and I'll talk to you all very, very, very soon. There's no pay in this for you, so don't look for a check.